Thank you for joining us for this really, truly important webinar on inherited thrombocytopenia. What is it, whom to test, and how to test? I'm Katrine Erickson, the Executive Director of the RUNX1 Research Program, and I'm thrilled to be co-hosting this webinar with my colleagues Caroline Cruz from the Platelet Disorder Support Association and Carrie Funkhauser from the Foundation for Women and Girls with Blood Disorders. I just want to briefly share a little bit about RRP for those of you who don't know who we are. We are a nonprofit organization, and our mission is to improve the quality of life and prevent cancer in patients with RUNX1 familial platelet disorder. We do this through both patient programs, patient support programs, as well as medical research funding. And to date, we've committed close to $8 million alongside our wonderful co-funding partners like Alex's Lemonade Stand Foundation, the Leukemia Lymphoma Society, and as well as Evans MDS more recently, and the Mark Foundation for Cancer Research. And all of the research that we fund is hyper-focused on the goal of discovering treatments for cancer prevention. Caroline, do you want to go ahead and introduce yourself and share a little bit about PDSA?
Sure, thank you, Katrin. I'm Caroline Cruz. I'm the President and CEO of the Platelet Disorder Support Association. We are dedicated to enhancing the lives of patients with immune thrombocytopenia and other platelet disorders through education, advocacy, research, and support. For over 20 years, PDSA has proudly served as a trusted resource for the scientific community, connecting ITP patients and caregivers with patient-friendly educational materials, programs, and support. In 2020, we launched the Healthcare Practitioner HCP Outreach Program to further support clinicians and connect the community with the latest ITP protocols, cutting-edge research, and innovative therapies being developed worldwide. We are proud to partner on today's program, and we are very proud that Dr. Michele Lambert and FWGBD's founder, Dr. Andrew James, are both PDSA Medical Advisors. Thank you.
Thank you so much, Caroline. And Carrie, would you like to introduce yourself and a little bit about the FWGBD?
Yes, thank you. Yes, good morning, everybody. It's a pleasure to be here. My name is Carrie Funkhauser. I'm the Executive Director of the Foundation for Women and Girls with Blood Disorders. As you very well know, menstruation, pregnancy, childbirth, and menopause present very unique challenges for women and girls with blood disorders. And when they're undiagnosed and untreated, they can have medical consequences at every life stage. And their delay or failure in diagnosing and treating are major health problems. They result in significant morbidity, reduced quality of life, days lost from work and school. And so the experience and training of 3 internationally recognized physicians in women's blood disorders, Dr. Andrew James, Barbara Conkle, and Roshni Kulkarni, underscored the need for a foundation really focused on education and awareness among providers. And their discussions culminated in the Foundation for Women and Girls with Blood Disorders in 2010. And since then, we've launched to serve as a single site of information and education for healthcare providers. Our mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. And we provide education for free via conferences, webinars, through our website. And we also partner with other organizations like we are today. So we're very proud to be here. Please visit our website for information and to learn more about us. So thank you.
Thanks so much, Carrie. Well, so to give all of you a little bit of context, this collaboration was born out of listening to patients and their stories, and not only at RRP, but as you just heard at PDSA and FWGBD, patients have shared their diagnostic odysseys when dealing with platelet disorders. And so together we felt it was really important that we try our best to help the medical community shorten the time to accurate diagnosis through this educational program. We have a wonderful group of guest speakers today. We'll start with 2 stories from a patient, Christina Timleck and Joy Anderson, a mother and wife of 3 patients who have been diagnosed with RUNX1 familial platelet disorder. And both of these women suffered through a very long diagnostic journey with receiving diagnoses that were not RUNX1 initially. Then we'll hear 2 presentations from experts in inherited platelet disorders, Katie Bergstrom, who is a pediatric hematology genetic counselor from the Seattle Children's Hospital, and Dr. Michele Lambert, a non-malignant pediatric hematologist from Children's Hospital of Philadelphia, and also, as you heard, a PDSA Medical Advisor. We'll host a Q&A session at the very end, and we'll bring back both patients and our two speakers to answer any and all of your questions. Please submit your questions anytime during the webinar. Just submit them through the Q&A icon rather than the chat. Of course, if you want to make any comments, you are more than welcome to through the chat icon. And I'll walk through and ask those questions at the very end. So with that, we'll now hear Joy Anderson, who will speak about her family story, and Christina Timleck about hers.
When Griffin, our oldest, was a baby, I felt something was not quite right. He bruised like a peach, and with those bruises came hematomas. I took him to our family doctor, where I was told I was just a first-time mom of an active boy. At the age of 3, Griffin was diagnosed with thrombocytopenia and platelet storage pool deficiency. Fast forward 7 years and many appointments later, a hematologist at Nationwide Children's Hospital suggested genetic testing. A genetic counselor was present at this appointment, and she presented all the precautions. One standing out was predisposing conditions to cancer. We decided, given possible outcomes, to move forward. I received a phone call weeks later from our genetic counselor on the other end of the line saying she had results. My child, blood disorder, gene mutation, cancer. That's all I could hear.
I started having bleeding issues when I was going through puberty and having my first period. A few months after my first period, I ended up having it for 17 days, and I was hospitalized, and my hemoglobin was at 46. And that's when they started testing me for various types of bleeding disorders. It was terrible. And being a young girl, I wasn't, and it was new to me, I wasn't sure what a flow should be like. So I didn't know that it wasn't normal. At that time, they called it prolonged bleeding time for ever and ever and ever. I have scars all the way up my arms due to all the bleeding time tests and all the different types of medications that they test on me and whatnot. 10 plus years to get a diagnosis of delta storage pool disorder, which is another rare bleeding disorder that's linked to RUNX1, definitely a long journey. But I have to give a lot of credit to our genetic counselor, the genetic counselor that I was put in touch with. And also that one person who was scanning me during my pregnancy who said, "Hey, have you ever seen a genetic counselor to see what the chances would be if your children would have your delta storage pool disorder?" Both of my two boys have RUNX1. They also have the delta storage pool. They are currently 3 and 5, and they're very, very busy boys. They're bruised quite often, and we just take it one day at a time and try and do what we can. We've had a couple of scary incidences, but they're doing just fine. They like to roughhouse and play, and I try not to get in the way too much, but boys will be boys. Perhaps maybe my story and how I came about to be diagnosed could possibly help other young women who are having issues with
their menstrual cycles. It's natural, it's normal. Every woman, you know, deals with it. So reach out and speak about your periods.
I want to thank you both, Joy and Christina, so much for taking the time to share your story. Your stories can help all of us learn and make sure that accurate diagnoses happen as soon as possible, and that your long diagnostic odysseys don't have to happen again. All right, I know we're probably going to have some questions for both of you, but as I said, we'll move to Q&A at the very end, and we'll have a discussion about all the questions then. So I'm going to now turn it over to Katie Bergstrom, who is a genetic counselor, as I mentioned, at Seattle Children's. And I'll let you take it over now, Katie.
Wonderful. Thank you. And thank you, Christina and Joy, for sharing your family's stories. It's always so impactful to hear directly from patients and families. I am hoping slides are coming up. Do we have those accessible? Or I can pull them up from my end.
Michelle, are you able to share? I'm wondering if, all right.
Excellent, sorry about that. So I'm going to be talking about some of the genetic counseling, testing, and considerations. We know that there are approximately 60 different inherited platelet disorders due to at least 75 different genes that we know about, which are highlighted here. It's really difficult to truly estimate accurately the prevalence and frequency of inherited platelet disorders because they are very much under-recognized. Many patients experience the diagnostic odyssey you heard about from Christina and Joy. And in so many cases, it depends meeting the right provider at the right time that tests for the right genes. And so you have to see how a lot of the dominoes have to fall in the right place. We would estimate that the prevalence is about 1 in 100, but again, I think as more and more people who have thrombocytopenia or some sort of platelet differences have access to genetic testing, we will see those numbers change over time. It's so important based on those factors to identify the patients who would most benefit from genetic testing, but then also that those people, just as Christina and Joy talked about, are part of the process to understanding the test, providing consent, and really understanding what we're looking for and what you can find by doing genetic testing. So the typical genetic counseling and testing flow is this multi-step process highlighted here, where we identify the patient, provide pre-test counseling, obtain that informed consent, facilitate the test ordering, which also sometimes is a challenge, but also disclosing those results and providing additional counseling at that time. It is so important as you're thinking about genetic testing to consider the possible results you may find. Of course, both Christina and Joy have shared their experience of receiving a positive result. And it's important for your provider to understand exactly how that positive result is going to impact your treatment and management, and if they're going to do anything differently based on what they're already doing for you based on your platelet symptoms. It's also important to have someone that is able to facilitate that family testing. We talked about then how they tested the kids in the family, testing parents. Is your provider able to see children or see adults is such an important question. It's also important to consider your reaction as a patient or a family, or if your provider, your patient or family's emotional reaction to a result. A positive result may feel very validating. I think both Christina and Joy shared that experience, but it also can be full of some fear when you hear the words cancer then thrown out, not maybe necessarily expecting that or know what to do with that. And then of course, having solace in a community. If you have a diagnosis, you can reach out to the organizations that are hosting us today and find that community based in that shared diagnosis. If someone receives a negative result, as the provider and clinician needs to realize what was the utility of the test itself. Were all the genes that we know of are associated with inherited thrombocytopenia disorders tested for, or was the test the right way to look at that type of gene? Gets really technical, but is a challenge that we all have to face when we think about doing genetic testing. In those cases, you wonder, is the family getting false reassurance? Are they being told that a condition's not genetic when it might be that the test didn't look for the right gene, or we just haven't discovered the right gene yet, which is why the ongoing research is so important. Also, when you do genetic testing, and I think Dr. Lambert will talk about this a little bit more, is the possibility of getting uncertain results. Is additional testing then going to be necessary to kind of clarify the uncertain genetic test result you received? And of course, you can always find an unexpected result. If you look more broadly at genes, more than just the platelet genes, you could also find risks for other health conditions, heart conditions, things like that, that might unexpectedly pop up. And then do you have the right team to provide additional evaluation for things you didn't expect to find? And then how would the family handle the additional stress of anxiety of maybe even not getting an answer for their platelet condition and being diagnosed with a completely secondary and unexpected condition? It's always important to understand the value of the test and a possible diagnosis to the family, and a balance of that satisfaction and reassurance or anxiety and uncertainty. And a genetic counselor can help you navigate all of those expected feelings. It's always important to talk about cost and coverage of genetic testing specifically. As you know, genetic testing is highly specialized and thus costly. It's testing that's available through certain types of laboratories. So not everyone does this type of test, and even your doctor, your specialist will have to send out this test to a laboratory with specialized certifications. We look for CLIA and CAP certifications. We strongly recommend everyone has insurance pre-authorization or predetermination in order to better understand any out-of-pocket cost a family might experience when you're doing this type of testing. And on that side, the provider can help by justifying the medical necessity. Some of the things I talked about earlier in the context of a positive result, how would your doctor change your treatment and management is going to be what the insurance company is looking for. I always mention the Genetic Information Non-Discrimination Act, which was signed into law in 2008, which protects an individual from discrimination by employers or health insurance companies based on their genetic information. There are important military and federal exceptions. So it's important, if you have concerns about this, to speak to a lawyer or speak to someone in the genetics community who's more familiar with kind of your specific situation and potential risks for discrimination. GINA does not protect from discrimination by long-term disability or life insurance companies. We don't deal with that too often in the pediatric setting, but it is a consideration certainly for adults before getting genetic testing. I know that was a quick high-level overview, and I'm happy to answer specific questions later in the Q&A. I'd also like to highlight the paper that I cited with some of the details about prevalence and frequency and the known genes is here. We've heard a lot of great stories already about the importance of involving a genetic counselor in the genetic testing process. If you do not currently have access to a genetic counselor, I'd encourage you to look for one at the National Society of Genetic Counselors, or nsgc.org. There are genetic counselors practicing in all 50 states and internationally. I'd also recommend the Seattle Children's Hospital Plugs program, which has resources to help both providers and patients and families navigate the insurance authorization and testing process, which can be a bit overwhelming, especially if you get into a series of denials or appeals, which often happen in genetic testing. And then, of course, our hosts today for all of this information they're putting together, but the programs that they do throughout the year, the RUNX1 research program, the Platelet Disorder Support Association, and the Foundation for Women and Girls with Bleeding Disorders. Thank you for bringing us together today.
Thank you so much, Katie. That was wonderful, and I'm looking forward to discussing more during the Q&A session. All right, Dr. Lambert, it is now your turn to share with us your presentation.
Okay, I'm going to try sharing my screen again. Let's see if this works this time. Come on. Can you see that?
No, we don't see your screen.
All right, hang on. How about now? Stop. How about now?
Yes, you can
Okay.
see it.
All right, so
You might show your video again too, if you can.
let me see if I can do that. Hold on one second. That might. How's that? Can you see me there?
Yes.
Perfect.
Okay. Katie, thanks so much for going through some of that information. I'm going to talk a little bit about recognizing the features that might make you think that this is an inherited platelet disorder versus ITP or maybe primary immune dysregulation, and talk a little bit about how important the role of the genetic counselor really is in testing patients with suspected inherited thrombocytopenias. And then talk a little bit about the risks of not recognizing alternative diagnoses and just plugging along and thinking that this is ITP. And then again, talk about some more resources for genetic testing and processes as well for obtaining that testing. So again, thanks to Katie for giving us that overview about the role of the genetic counselors. I think for me, the importance of the genetic counselor is that they really have all of that background knowledge in the types of testing, which test is the best test to send, and really can help to facilitate getting that testing approved and helping to draft that medical necessity letter for the insurance company so that it can facilitate that process and make it happen a lot more easily. And also can communicate with the families and help us to present the most balanced view and help us to really understand where the family is in wanting to know the information that is potentially available from getting the genetic testing done versus just needing to know information that we need in order to be able to treat them. Because not every family is really ready for a genetic diagnosis potentially. So it's important to get the right diagnosis, but in some cases we have a clinical suspicion of where that general diagnosis is going to be. And so we can start to manage the patient in that direction without necessarily landing on the exact molecular diagnosis. If a family, for example, is so anxious about that potential cancer risk diagnosis that it's better to them to not have the molecular diagnosis, and they're just not ready to have that name on their platelet disorder. But for some families, they need to know. They need to know, yes, this family member has the risk of developing cancer, and this family member definitively doesn't have that inherited risk factor for developing cancer. And so they just need to know that information. And then once a family is aware of the reasons for doing the testing and the potential outcomes for doing that testing, I think it's really important to come to a mutual decision about whether or not to proceed. And as a pediatric hematologist, I think then it's really important to also make sure that we involve the patient, who is often a child, in that decision making. So if it's an adolescent, it's critically important that that adolescent is in the room. So if it's a teenager or somebody who's even 10, 11, or 12 years old, they really need to be in the room during that discussion. And the discussion has to happen at their level so that they can be part of that discussion. If it's a 6 or 7 or 8-year-old, that child also needs to be able to be part of that decision making. And if it's a younger child, then I often will encourage families to think about when is the right time to do the testing, and how we can proceed with managing a patient potentially without necessarily a molecular diagnosis, so that that patient can be part of that decision-making process. So what's the downside of just calling it ITP? I think, first of all, what is ITP? Well, it is a clinical diagnosis. There's no specific lab test that tells you that it's ITP, and ITP stands for immune thrombocytopenia. And so it's an isolated, acquired low platelet count in an otherwise well patient. And this diagnosis is really based on history, the physical exam, and a CBC with differential review of the blood smear and review of the blood smear. And so because there isn't a definitive test to say that it's ITP, most often patients who have thrombocytopenia in isolation are diagnosed as having ITP when we don't know why their platelet count is low. If there is a response to specific ITP therapies, such as corticosteroids or IVIG, that can be helpful to make the diagnosis. But most of the time when we order other tests, they're really to rule out alternative diagnoses, not so much to make the diagnosis of ITP. And primary ITP means that you don't have underlying immunodeficiency or autoimmune diseases that predispose you to get ITP. And most ITP is primary ITP. About 80% of the time, it's primary ITP. But in about 20% of cases, it's secondary to something else, either an autoimmune disease or an underlying immunodeficiency or an underlying infection that deregulates the T cells and causes you to make autoantibodies against platelets and then develop secondary ITP. Secondary ITP is more likely to be chronic. And then in those cases, the treatment really needs to be directed at the underlying disorder that caused you to get secondary ITP in order to make that ITP get better. And so when a patient presents with thrombocytopenia, it's not only important to figure out, do they have an inherited thrombocytopenia or ITP, but also is that ITP primary or secondary? So what ITP alone really isn't, ITP by itself is not a cancer predisposition, and ITP by itself is not an immunodeficiency unless you've had a splenectomy to treat your ITP. But even if you have ITP alone, it can still be a difficult and potentially life-changing diagnosis. So I think it's important to recognize that no matter what the cause of the thrombocytopenia and bleeding symptoms is, that is a really potentially significant diagnosis for the patient. There are many times when patients see a clinician and are told, oh, it's just ITP. And then they're sort of told not to worry about it. And sometimes then there's no further digging if the patient doesn't respond to the appropriate treatments. But there are potentially problematic treatments for ITP, and particularly if it's not the right diagnosis. So corticosteroids can give you that moon face, that Cushingoid appearance. They can lead to secondary diabetes and problems with controlling blood sugars, and high blood pressure can lead to osteoporosis and even fractures as a result of soft bones, avascular necrosis, and changes in the spinal bones. And so, you know, here's a picture of that cute little squirrel with his cheeks all puffed out. Take prednisone, they say, you'll feel better. And then other potentially problematic treatments for ITP include splenectomy. For some types of thrombocytopenia, splenectomy is effective, but it's not useful in many of the inherited thrombocytopenias. Other immunosuppression may be potentially dangerous in the setting of an underlying immunodeficiency, or if you have another reason for your thrombocytopenia that's not ITP, and it won't work to raise your platelet count. And the TPO receptor agonists are very popular drugs now for the treatment of ITP, they actually work in a lot of other thrombocytopenia syndromes. And so you may respond to a TPO receptor agonist and not have ITP. And so just because you respond to a TPO does not necessarily mean that you have the diagnosis of ITP. So assuming that you have ITP may result in prolonged treatment with corticosteroids or splenectomy that may not necessarily be effective in the setting of the correct diagnosis. It may also exclude the correct monitoring. For example, we don't routinely do bone marrows in ITP treatment, but for some patients, for example, for some of the cancer predispositions, we would want to do a bone marrow evaluation. And so you may accidentally exclude the correct evaluation if you incorrectly diagnose a patient with ITP. And then, of course, there's family testing and counseling that may not be appropriately offered to families if you have the incorrect diagnosis of ITP. So it's really important that we land on the right diagnosis when we're managing patients who have thrombocytopenia, because ITP is not familial. And if you have ITP and there are multiple family members in your family who have ITP, then that is not the correct diagnosis. Features that suggest an inherited thrombocytopenia to me is if your platelet count's never been normal and you don't have any normal documented platelet counts, then that's not likely to be ITP. If the platelets look different, if they're abnormally large and consistently large size or abnormally small, if they have abnormal granules or abnormal granule release, then this is not likely to be ITP. If there are other congenital abnormalities associated with that ITP diagnosis, such as a heart defect or renal defects or problems, if there's skin or nail changes or bony malformations, or if there's a family history of either a low platelet count or leukemias or lymphomas, that suggests to me that you have an inherited thrombocytopenia. And another abnormality that would suggest to me that you might have an inherited thrombocytopenia would be hearing loss. Other features, if your ITP doesn't respond to typical ITP therapies, if you fail to respond to corticosteroids and IVIG, then you probably don't have typical ITP and you really need to rethink that diagnosis. If your patient has unexpected or frequent infections, then this is probably not primary ITP. And again, if there's a family history of multiple family members with ITP, either it's an inherited thrombocytopenia, or if they really truly have ITP, then there's an immune dysregulation that's running in that family. And that needs to be appropriately diagnosed as well. So again, why does it matter? The treatments really vary. If it's an immunodeficiency, you want to make that diagnosis if it's an immune dysregulation. And if it's an inherited platelet disorder, you're not going to respond to ITP therapy, or you may do harm with your ITP therapies. The risks for other associated conditions vary depending on the condition. For example, immunodeficiencies can be associated with other autoimmune phenomena and infections. The myosin heavy chain 9 related disorders can be associated with kidney and hearing dysfunction. The RUNX1 and KRD26 variants are associated with increased risk for leukemia. Wiskott-Aldrich syndrome carries a risk of developing lymphoma, as well as immunodeficiency associated with that. And a bone marrow transplant might be the right therapy, for example, for Wiskott-Aldrich syndrome, whereas for some of these other conditions, you would not necessarily offer that therapy. And then, of course, the possibility of passing the disorder really varies depending on the right diagnosis. And so, again, it's really important to make the correct diagnosis. So how do we navigate this changing landscape? There's lots of different sequencing options. And I think it's important to really involve our genetic counselors in trying to decide what testing we want to do, and whether we want to go with something broad like exome or genome sequencing, or if we want to just use single gene or sequencing panel. And I think, again, it depends on exactly what we're trying to understand about that particular family and what our level of suspicion is for a genetic disorder. An important thing to remember about exome and genome filtering, exome and genome testing, is that these results rely heavily on variant filtering. And so those variants are chosen based in part on the phenotype and on the variant themselves and the predicted effect of the variant. So information about the patient is key. And as Katie said, insurance approvals are really important and should be, authorization should be obtained prior to sending the testing. And you're going to need information like the CPT code and a letter of medical necessity. And often it requires a peer-to-peer. So it's really helpful to get your genetic counselor involved. And some insurance companies actually require that you have genetic counselors involved with the testing and have a genetic counselor visit in order to approve the testing. But very few commercial entities actually provide the assistance with navigating the approval process. So certainly the insurance companies don't want to make this easier for us to do. So it's really important to work with our genetic counselors to help get this done and to do this well for both our patients, for our patients' sake, and also for our sake, to make sure that we're doing this as well as we can do it. I think it's important to think a little bit about the economics of testing as well. Sometimes people balk at the price of exome sequencing, but when we think about how expensive it can be to do all of the testing that may lead to a diagnosis just test by test, it's not necessarily cheaper. So if we wanted to do, surface marker evaluation by flow cytometry plus platelet function testing, that's gonna cost quite a lot of money depending on what markers we're looking at and what lab we send it to. That testing tends to come back relatively quickly, but can cost quite a bit and is subject to the need for interpretation. Targeted sequencing comes back relatively quickly, but for example, can cost a couple $100s per gene. So if you're looking at, for example, for Bernard-Soulier syndrome, you're looking at 4 genes sequencing, so about $1,200 to do the testing. If you wanted to do next generation sequencing for Bernard-Soulier syndrome and reflex to a larger panel, if that's negative, depending on where you want to send it, it can be as little as $1,000 or even depending on which company you're working with and whether or not that patient has insurance coverage and the ability to pay. Some companies can even do reduced cost testing for patients who have to pay out of pocket. So sometimes the testing can be even less expensive than that. But that turnaround time is usually significantly longer if we're going to do next generation sequencing. So I recently just went back and looked a little bit at what we've done for our own patients here at CHOP. And when we looked at our patients with thrombocytopenia who presented and split them up into chronic ITP, those who had chronic ITP and an inherited platelet disorder, in about 2/3 of patients, we were able to get a definitive result based on sequencing. And this includes those patients who had pathologic and likely pathologic variants or or variants of uncertain significance that we were later able to definitively characterize based on functional testing. In our chronic ITP patients, you can see that over half of those patients, actually about 3/4 of those patients over time were eventually diagnosed with either immune dysregulation or rheumatologic disease. And so many of our patients who have chronic ITP, when we do an in-depth evaluation, we're able to make a secondary diagnosis in those patients who have longstanding chronic ITP. So I think it's important to think about sequencing is only as good as the phenotyping. Think carefully about what sequencing you're sending and why. And so our genetic counselors are really important to help us to determine that. And having a clear discussion with the family about what this testing can and cannot do is really important. Overall, it's not that expensive compared to what all the other testing can do or ends up costing, but insurance companies are still very reticent to cover the testing. So we often need to educate our insurance colleagues as well about how this kind of testing is not experimental and really does impact the way that we take care of our patients. There are lots of additional resources now that are becoming available to help us to understand the results of our testing. I think ClinGen is a collaboration that is international and working really hard to help to define all of the variants for many of the genes of clinical significance. So they're defining both the genes that are important and the variants that are important. So you can go to clinicalgenome.org and put in your gene and then put in your variant to see whether or not that variant's been described before and whether or not it has a rating. There's a RUNX1 database that's being curated as well. The North American RUNX1 and Inherited Hematologic Malignancy Predisposition Consortium is really just getting going, but hopefully will be a valuable resource as well. The Pediatric ITP Consortium of North America, or ICON, is working really hard to help understand pediatric ITP. And then these are a couple other commercial entities, that also offer pretty good genetic testing for inherited platelet disorders. And so with that, I thanks for your time, and I'm happy to help answer questions. And particularly, I want to thank those people who put together this this webinar, PDSA, the RRP, the Foundation for Women and Girls with Blood Disorders. I want to thank Katie for her time, and Christina and Joy for sharing their family stories, and of course, all of our patients and families. So.
Thank you so much, Dr. Lambert. That was also a highly informative presentation. If we could have actually Katie and Christina and Joy join us again, then we can have our Q&A session officially. The first question that I'm going to read off here is, there are so many outside centers that perform inherited thrombocytopenia panels. How do we go about deciding which testing is best? Are there specific centers that you would recommend? And I think this could probably go to either you, Katie, or Dr. Lambert.
Dr. Lambert, I know you just touched on this a little bit, so if you want to start, I might add in.
Yeah, I mean, I think what's really important is choosing someplace that has experience with interpreting the test. So you want to make sure that it isn't that you're going to that you work with your genetic counselors, because they are going to know those places that that do the testing on a regular basis and have experience with actually interpreting those variants and knowing which ones to call as pathologic and which ones are benign. I think because that's really the important thing. You want to make sure that you get a result that you can actually clinically use. And so I often will work with my genetic counselors and be like, so who's the best person to send this test to? And this is what I suspect might be going on with this patient. Where would you recommend I send the testing? I actually call the genetic counselors all the time. I have them on speed dial on my phone. We don't have a specific heme genetic counselor, so I'm just making our people learn, all of our people learn the heme testing at our place.
And I'd also give a shout out to the laboratory genetic counselors who are excellent resources. If you're in a similar boat in your institution, you don't work directly with a genetic counselor or have a genetic counselor on speed dial, many of the testing laboratories also employ genetic counselors who you can reach out to via phone or email and can help answer specific questions about their testing. I'd also encourage you to talk to your specific institution if you're an ordering provider, because many institutions have limitations in terms of billing, whether they do institutional billing or direct insurance billing to the patient. That might influence which laboratory you need to use just based on kind of the established relationships with your institution.
Great, thank you, Katie. I have one follow-up question, Katie, regarding the resource you mentioned at the end of your presentation. You said there are a number of genetic counselors that work in every single state, and you can go to the National Society of Genetic Counselors to access them. But what does that actually look like? Do you have sort of freelance relationship then? How does that work?
Sure, that's a really good question. If you look at the National Society of Genetic Counselors, kind of find a genetic counselor, there's a lot of tools to filter by. So you could filter by hematology expertise. I will say, as Dr. Lambert mentioned, there's not that many of us out there. So sometimes you might need to find a genetic counselor that's in your hospital system based on your insurance plan. But if it's not a genetic counselor with hematology expertise, we all speak very similar language, and they may be able to reach out to a hematology colleague like myself. So don't not choose someone just because they're not a specialist in hematology, because there are very few of us.
Great, thank you for that. All right, the next question. If your patient did at one point respond to steroids and other first-line agents and then suddenly stopped, is that the same warning? Is that the same warning flag as never responding? In other words, would you then think that this is not ITP?
So that then makes me think about immune dysregulation, and not so much an inherited platelet disorder, but whether or not there's something that's changed about the immune system. And in those patients, then I think about retesting the immune system and what's going on and how that immune system is functioning, whether there's something different about that.
There's a related question, which is, it's what situation might you order an inherited thrombocytopenia panel versus a platelet function disorder panel?
Katie, you want to take that one?
Sure, I will say it's important to look at, if you're comparing panels side by side, I imagine some of these have some significant overlap in the genes, but also some of the functional studies that Dr. Lambert has mentioned might give you some additional clues as to which direction to go. So it does get a little bit nitty gritty as you pull up the two panels and kind of what's included on them.
Then there's another question again, which kind of is a follow-on, asking, some of the platelet testing can be very difficult if you don't have enough platelets to test and they're too low. Any recommendations for triaging patients if you're unable to perform these tests?
Yeah, I mean, I think you have to work really closely with your lab, and there are some tests that you can get some information from, and you just have to know what you can do with the lab that you're working with. So, for example, if you can't get platelet function, but you suspect that the platelet function is abnormal, you could think about sending platelet EM, which you can usually do even when the platelet count is low. If you think that or you can try to get flow, you should be able to get flow cytometry. It's hard to get functional clinical testing by flow cytometry, but you should be able to get some of the surface markers and stuff like that. So it's just really important to reach out to the lab and try to figure out what kind of testing you can get in order to get functional testing. But again, sometimes you have to get the genetic testing because you just can't do the functional testing.
Is there ever a time where you would just pass the functional testing, go straight to genetic testing, where it makes no sense?
Yes.
Yeah. Straight and easy answer. Okay. Another specific question here for you, Dr. Lambert. Why do you think that you've been able to identify definitive results, I think, in 67% of your inherited thrombocytopenia patients? And that's in contrast to the Italian group led by Dr. Balduini, who identified 40% or less in his patients or in their patients.
That's a good Dr. Bucell asking that question. And Jim, I would say that's because I've carefully selected which patients I send the sequencing on. And also because we had the ability to do some functional testing to validate some of the variants. So I think I'm cheating a little bit compared to what some other groups are doing, but.
Thank you. There's a question around, there was a discussion about the medical necessity letters, and a couple questions there. First, how often do you find that you need to provide a medical necessity letter for these kinds of patients? And then secondly, do you have standard letters or templates that could be created and made available? Maybe Katie?
Sure. So I would encourage, before you even submit a request for genetic testing, that you have documented in your clinical notes the medical necessity. That kind of avoids maybe a go-between step where you then get contacted by insurance after they've had several weeks to look at it to say, we need your medical necessity. So I would encourage you to have maybe your own standard language. It should be, patient specific about your concerns about the patient's diagnosis and your potential treatment plan. So it's hard to have templated language, though generally for a lot of these conditions, and I think we've talked about this a little bit, there are some specific management recommendations and things that you would probably do if the test was positive. So something along the lines of, would you otherwise do bone marrow biopsy in someone who has thrombocytopenia? Anytime you talk about a more invasive test, I think insurance would pay attention to that. Or if you were considering something like a bone marrow transplant, of course, that's something that's important as you think about working up familial donors for something like that. So those are typically some of the things that I point out in some of my medical necessity language, but please, I'd encourage you, do it upfront.
Yeah, I totally agree. 100% of the time, if I'm sending genetic testing, I write a letter of medical necessity. It saves you one step, it saves you that initial denial, and then having to go back and resubmit again for that with the letter of medical necessity. So I just write the letter the first time and then submit it with that in the first submission.
Great, thank you both. Another question here, do you use ANA screening as part of your workup?
I do not routinely do an ANA in every patient with ITP. I do ANAs in adolescent females who have ITP. I do an ANA in an adolescent male who presents with ITP because that's weird. And I do, and I look for other reasons for that patient to have a low platelet count. And I do, but I don't necessarily alter my management initially based on what the ANA looks like. Unless I have additional symptoms or signs that point me towards an actual rheumatologic diagnosis. So, but lupus is a very frequent secondary diagnosis, particularly in the adolescent patients with ITP. So, and especially adolescent females. So it's definitely something that's on my radar and something to look for.
Great, thank you. We have so many questions. Thank you for these fantastic questions. We're going to keep going until the time out. Are there any specific inherited thrombocytopenia in specific panels you would recommend as a starting point? So we've talked about now several companies out there, and there's also academic institutions. Is there any or maybe 3 panels that you think are just really comprehensive?
Go ahead, Katie.
Oh, sure. I'm going to refrain from endorsing a specific lab because of all of the logistics I mentioned. That depends on your institutional billing policies and relationships. And I would discourage thinking about genetic testing as a starting point just because of some of the things we talked about in the possibility of uncertain results. It is helpful to have some other initial maybe workup done to help you interpret the results that you get, or like Dr. Lambert mentioned, making sure you're giving the lab a full clinical picture to the patient so they can properly interpret the genetic test results. So yes, I will say I've worked at multiple institutions and my answer would be different depending on where I'm working to your question. So I'm sorry, I can't give you a specific. I don't know, Dr. Lambert, if you want to.
Yeah, I mean, you know, my answer depends also on where you're practicing, because it is a little bit institution dependent. There are some labs that that have a lot of experience with doing it, and so they're good places to send it. I think if there are a lot of genes on the panel and those genes are all validated genes that that are listed in ClinGen as genes that are associated with thrombocytopenia, that's probably a good panel. So, and then if they have a genetic counselor that helps to interpret that testing, that's probably a good lab to send it to. So I think that those are things, clues that will tell you that it's a good place to send your testing. If you call them and they don't have a genetic counselor that you can talk to help you to decide whether it's a good place to send the testing, don't send it there, and find someplace else to send it. And I think also if they don't have somebody that you can talk to about helping to get the testing approved, that probably also means you don't want to send it there. I think those are the big things that I would say about deciding where to send the testing. And if they can help you with those things, then you have found a good lab to send the testing to because they know what they're doing.
That's a really helpful, insightful framework in terms of the criteria to think through when starting off and thinking about testing for these inherited platelet disorders. Well, I want to thank all of you. I want to thank Katie, Dr. Lambert for just wonderful presentations and for answering all these questions. A special thank you again to you, Joy, and your family, and as well as Christina Timleck. I think she had to jump off, for sharing your story. It's always so grounding and so helpful. And then finally, I want to thank our collaborators, the PDSA and FWGBD, in helping us put this on. And of course, Catherine Pelton and Amanda Eggen, who are at the RP and who did most of the heavy lifting. So thank you, everyone, and thank you for joining. And we hope to see you at our next webinar in the future. So stay tuned. Thank you.